Good morning or good afternoon, and welcome to an EAS webinar on medical food regulations in the US and EU presented by EAS independent consultants, Dr. Timothy Morck and Dr. Manfred Ruthsatz. EAS, a member of the certified group of companies, is a leader in regulatory solutions for industries regulated by FDA. Our global network of over 150 independent advisors and consultants enables EAS to provide comprehensive training, auditing, and consulting services. From regulatory strategy development, compliance assistance with food safety and HACCP, preparation of technical submissions such as GRAS, food contact notifications, as well as support for receipt of FDA Form 483's warning letters, and preparing for FDA inspections, EAS offers the detailed knowledge and experience your company requires to ensure accurate and timely assistance. Today's presenters are Drs. Timothy Morck and Manfred Ruthsatz. Dr. Morck provides expertise in nutrition-related product development, regulatory, and public policy. His career has spanned clinical nutrition practice, personalized nutrition startups, and tenure at the Dan & Company, Mead Johnson Nutritionals, Abbott Nutrition, Nestle Health Science, and Nestle Corporate Affairs. Tim has particularly focused on the interplay between the legal, scientific, and regulatory framework surrounding medical foods. Dr. Ruthsatz facilitates global, specialized, and personalized nutrition product development strategies, resolving compliance issues while advocating for nutrition therapy and regulations and policies, including those in the EU, Americas, and Asia. Prior to consulting, he worked as global head of regulatory advocacy at Nestle Health Science, global headquarters, Switzerland. Manfred's focus lies in connecting advocacy, regulation, empathy, care, to share his experience and passion for nutrition and healthcare, healthy aging, and gut microbiome. As a reminder, to ask any questions, you can type them into the questions box during the webinar. And as well, you should have received the slide handouts in advance in your email. And with that, I will say thank you for joining EAS, and I'll turn the presentation first over to Tim.
Thank you, Amy. I'm really pleased to have a chance to talk with the audience today about medical foods. My title is Science Surpasses Regulations, and I hope by the end of my session, you'll probably understand what I mean by that. Okay, here's what I intend to cover in this next several minutes. I'd like to give a regulatory history of medical foods, which focuses on some of the key elements of the framework that we have to abide by, talking about a difference between a statutory definition and a regulatory interpretation of the legislation that brought medical foods into creation, and then some of the terms: distinctive nutritional requirements, modification of the diet alone, delineating between different categories of foods that would avoid being accused of making drug claims. And then at the end, some of the challenges that are still confronting the medical food category and how EAS can help. I'll come back after Manfred talks a bit later. So I want to begin by saying history is important. It gives the backdrop, but I'll warn you up front that there's a lot of words and a lot of text on my slides that are coming up. Amy informed me that she sent this presentation out to you all, so that makes it easy for your note-taking. And so I won't have to cover all of the information, but I do find it's important to talk in the definitions. The actual words are very important and they have regulatory meaning. So back to the early history. Before 1972, the infant formula lofenalac was a product that was specifically designed to help manage the genetic defect of babies and children that were born with phenylketonuria, PKU as we know it. And this was a very limiting amount of phenylalanine, but with all the other essential amino acids and vitamins and minerals. In late 72, lofenalac was moved out of the drug category because it was for treating a genetic condition, moved into the Foods for Special Dietary Use, FSDU, which we'll talk about somewhat later as well. And then lastly, in 1988, the Orphan Drug Act amendments were passed by Congress, and they created and defined the category of medical foods, a category separate from drugs, yet were associated with disease. Now, in this slide, this is the one I really want us to start with, because this is the actual wording. It's a short paragraph, but it contains the actual definition embodied in the law, the Orphan Drug Act amendments that created the category of medical food. So the term medical food means a food which is formulated to be consumed or administered enterally. Now that means, in contrast to parenteral nutrition, which is intravenous nutrition, medical foods are intended to be given enterally under the supervision of a physician, and which is intended for the specific dietary management of a disease or condition for which distinctive nutritional requirements based on recognized scientific principles are established by medical evaluation. Now, I'm hoping that in the printout that you have, these highlighted text at the bottom of my slides will be able to take you directly to the web link that you can see where this comes from as it is. Now, I want to point out just a few differences between drugs and foods. Pre-market approval, pre-market review of safety and efficacy, pre-market review of label claims, product registration, mandatory adverse event reporting. Those are all hallmarks of what it requires for drugs to be brought to market in a safe and effective way. None of these apply for medical foods. That's the point of this slide, is to show that medical foods are completely different. They do not have any pre-market approval requirements. You do not need to notify FDA in advance, but they are still, nonetheless, have restrictions that we'll touch on in a second. First of all, they must not be adulterated, and they must not be misbranded. Now, adulteration means that the products are safe under the intended conditions of use. All ingredients, because it's food, are safe food additives, or they've been determined to be generally recognized as safe, GRAS, through external or internal review committees that in some cases are self-affirmed, other cases are submitted to the FDA. And in the manufacturing, they must follow good clinical good manufacturing practices with registration and periodic inspections of the facilities to make sure that the record keeping and the quality systems are in line with what safe foods need to be. Now, being not misbranded means if there are label claims, they must be truthful and not misleading. And the labels must conform to applicable food labeling regulations, although there are certain exceptions from standard nutrition facts labeling, and there are also some exceptions regarding health claims and nutrient content claims. We could spend a lot more time in this area, but just suffice it to say that these are some of the hallmark criteria of medical foods. And finally, as I alluded to, FDA's enforcement authority is post-market surveillance as opposed to pre-market approval. Now, this slide shows a number of tools that can be used by FDA for post-market enforcement. And we see that one of the primary ones is marketplace monitoring. Now, historically, that would be someone would go into a store, look on shelves, see what the products look like, maybe take some home, evaluate the labels. Now, essentially, there's a lot of time spent going through websites, looking at postings where the product is being sold, what it's said about it on websites, in social media, all to determine what is the intention of whoever is marketing this product, what is the intended way in which it is brought to market, and that it needs to be brought to the patient's attention. So along with this adverse report, event reporting, facility inspections I mentioned, one thing to point out, if you are importing a product outside the US into the US to be marketed as a medical food, there is a guaranteed examination point in the customs process. So you are assured that your product will be stopped, it will be looked at, reviewed, and in some cases detained if there are any questions that arise without physical examination. So this is a difference between importing a medical food from outside the country or making it within the country that sort of detention is not always a given. Warning letters, seizures, injunctions all follow if there are issues FDA has with your product, and the latter two if you choose to ignore them and they have to resort to more serious ways. Now, I want to bring up, that was 1988 that the creation of the category was made. In 1990, Congress passed the Nutrition Labeling and Education Act, NLEA as we familiarize it as known. And in that context, the labeling requirements exempted medical foods from some of the certain nutrition labeling criteria, such as nutrition facts, but also health claims and nutrient content claims requirements that were applicable to most other foods were exempted in this context. In 1993, after the law was passed in 1993, FDA implemented regulations, the implementing NLEA regulations. And in that context, there were 5 criteria that they identified that must be met to qualify as a medical food and as to be exempt from this nutrition labeling. I want to go through each of these. Again, this is the important wording. It is wordy, but each one of these is important. And keep in mind that the medical food meets the criteria only if all 5 of these are met, not just 3, not just a majority, but each one of them. So the first one is it's specially formulated and processed product in contrast to a naturally occurring foodstuff used in its natural state. And again, for the partial or exclusive feeding of a patient by means of oral intake or enteral feeding tube, similar to what we heard in the statutory definition. It's intended for the dietary management of a patient. Now here the wording is slightly different from the legal term, which said dietary management of a disease. FDA is very careful to make a distinction between products that are used to manage a disease, which are only drugs, and products, in this case, for the dietary management of a patient, which is a nutritional support. So it's intended for the dietary management of a patient who, because of therapeutic or chronic medical needs, the patient has limited or impaired capacity to ingest, digest, absorb, or metabolize ordinary foodstuffs or certain nutrients, or who has other special medically determined nutrient requirements, the dietary management of which cannot be made just by modification of the normal diet alone. Thirdly, it provides nutritional support specifically modified for the management of the unique nutrient needs that result from the specific disease or condition as determined by medical evaluation. And fourth, therefore, it's intended to be used under medical supervision as opposed to direct to consumer, I will just point out parenthetically. And what about this medical supervision? Well, it's intended only, and it says only, for a patient receiving active and ongoing medical supervision wherein the patient requires medical care on a recurring basis for, among other things, instructions on the use of the medical food. I took the time to go through each of these points because the wording here is very important. And I want to be clear that from the one paragraph that we talked about a minute ago as the definition in the statute, these 5 points are what the regulatory agency uses to determine whether the products in the marketplace meet the criteria for medical food. So in a nutshell, they're not products simply recommended as part of an overall diet to manage symptoms of a disease or condition, to reduce the risk of a disease or a condition, and not all foods fed to patients that have a disease that requires dietary management are considered to be medical foods. We'll see that a little bit later in some of the guidance documents where they point out, as an example, that diabetes requires dietary management, but FDA considers that you can modify your diet to be compatible with the recommendations for diabetes intake or dietary management, and that it does not require specifically formulated medical foods to do that. And then lastly, medical foods are different from certain other specialized food categories, such as dietary supplements, foods for special dietary use, but are the only products that are permitted to make disease association claims in a nutritional context, such as this medical food is appropriate for the dietary management of patients with X, Y, and Z, and we'll touch on some of those. Now, what are foods for special dietary use? FSDU by abbreviation. This was a term that was applied back in the late 70s and actually predated the lofenalac we talked about. It was moved into this category out of the drug category, but they supply particular dietary needs that exist by reason of physical, physiological, pathological, other conditions. And this includes a number of conditions of diseases, convalescence, pregnancy, lactation, allergic hypersensitivity to food, underweight, overweight. All of these are saying that there's specialized nutritional needs for patients in a number of these categories, and these foods have been designed for special use. They also refer to age-specific conditions such as infancy and childhood. And lastly, they're supplementing or fortifying the ordinary or usual diet with vitamins, minerals, other properties. And you'll see in a second that this aspect was actually the basis for creating the new category of dietary supplements. That happened in 1994. Again, statutory legislative law passed the Dietary Supplement and Health Education Act, DSHEA, and this provided the definition for dietary supplements that distinguished them from other conventional foods. It removed them from the category of foods for special dietary use into a brand new classification of dietary supplement, and it did not bring dietary supplements under the definition of medical foods. So they remain distinctly different, and for purposes that we'll talk about in this slide. It means a dietary supplement is intended to supplement the diet that bears or contains one or more of the following ingredients. Now, this is, you've seen many of these on your store shelves: vitamins, minerals, herbs, botanicals, an amino acid in some cases, or a dietary supplement substance for use by man to supplement the diet. Okay, that sounds kind of obvious, but nevertheless, it also could be a concentrate, metabolite, constituent, extract, or combination of any of the ingredients above. But number 2 says it's not represented for use as a conventional food or as a sole item of a meal or the diet, and it's labeled as a dietary supplement. So I want to give credit to Dr. Pat Hansen. She's the Deputy Director of the Office of Nutrition and Food Labeling within the Center for Food Safety and Applied Nutrition at FDA. She gave a very nice presentation on this topic at a conference that I was organizing back in November of 17. And this is her slide. I want to give her credit for that because it's very nice. It shows the distinct delineation between drugs as a separate category and then foods, and shows how several of the things we've just mentioned all are part of the food category of the FDA. Most foods, food for special dietary use, dietary supplements, infant formula, and medical foods in the red highlight. What's interesting is infant formula, even as a very specific category, the exempt infant formulas, which are uniquely fortified and formulated for children, for babies and infants that have metabolic conditions like inborn errors of metabolism, are very similar to medical foods. And so there's a kind of a link to that as a category. Now, other regulatory activity in 1996, now again, we were just talking 3 to 4 years after the medical food was defined in the NLEA. Now there was FDA recognizing that there was a need to clarify some of the terms that we went through in the early definitions. And so they issued an advance notice of proposed rulemaking, a process that FDA uses regularly to invite comments from industry, from the public, from the scientific community, and the comments about their questions for which they would then use to revise the regulations. Some of the reasons given for why this was necessary now is that they saw a rapid increase in the variety and number of products that were marketed as medical foods. The uses for which some of them were being marketed were not always clear cut that they met that previous definition, so they felt there was some definition clarity needed. There were reports of safety problems and potential for consumers to be injured or misled from unsupported claims. As part of this ANPRM, which is very extensive, it's published in the Federal Register. I believe it's something like 11 pages of 3 columns, very small print, so very detailed. But in part of that, they suggested maybe there's 2 ways to interpret the phrase distinctive nutritional requirement, which you heard about in the statutory definition. Maybe there's a physiologic interpretation where specific nutrient needs are different for patients that have a disease or condition. The needs for those nutrients are different than the healthy population at large. Or as an alternative, maybe certain patients have the limited ability to obtain nutrients, but that their requirement for these nutrients are not different from what a normal person in the population would have as a dietary requirement. So as an example of the second one, think about patients with dysphagia, chewing and swallowing disorder, where they can't eat normal solid foods, or they can't take clear liquids or liquid foods because they might choke on them. So they have thickened beverages, they have other specially formulated products to make the ability to obtain the nutrients safe, but they don't have different requirements for the vitamins and minerals than the rest of the population. Now, other terms that they went into a lot of detail in the ANPRM include, what does use under medical supervision mean? How do we interpret the specific dietary management of a disease without saying we are curing or treating or mitigating the symptoms of the disease, but we're actually managing the dietary needs of the patient? And then the need to substantiate, how do we interpret the research data and establish nutritional efficacy in claims made in product labeling? Unfortunately, 8 years later, in 2004, the Federal Register had this notice that because of competing priorities that have tied up FDA's limited resources, the agency has been unable to consider in a timely manner the issues raised by comments on the ANPRM and does not foresee having sufficient resources in the near term. Therefore, the agency is withdrawing this ANPRM. But I will point out that they go on to say the FDA continues to believe that the basic principles described here provide an appropriate framework to understand the regulatory paradigm governing medical foods. So they advise they'll continue to refer to the basic principles and in FDA's Medical Foods Compliance Program. I urge any of you who are seriously interested in medical foods to follow this link on the bottom of this page and read this in detail, not just the with traction, but the actual ANPRM document, because it does lay out a lot more thinking, and it points out that the agency they knew that things were not as clear as they should be, but they were asking for help. Unfortunately, as so often the case, the good people and scientists at FDA were just overwhelmed by other priorities, and this just couldn't be addressed. So in 2016, they thought, well, let's at least give some guidance for industry, and they published in final form the frequently asked questions about medical foods, the second edition. And here, they're not binding recommendations, but they are clarifying statements in a Q&A format to help understand the definition, the types of diseases and conditions appropriate and inappropriate to be considered, and things like they were seeing on some inappropriately labeled so-called medical foods, phrases like RX only and NDC, the National Drug Code numbers, in order to try and get reimbursement. But they made it very clear that RX only is reserved only for drugs. It should not appear on a medical food label, and NDC numbers were not appropriate for medical foods either. So the challenges that continue to confront the medical food category is that the clarity is still lacking in some of these key terms. Now, I pointed out the difference between dietary management of a disease or condition versus dietary management of a patient. But here are some other terms that 25, 30 years later have never been clarified. And yet, think about it. How far has the science progressed in that same several decades so that we know so much more about how the body uses precursors, bioactive components in food, and can be beneficial to patients, but the regulations have not kept up with the science. Things like, how do you determine distinctive nutritional requirements? What's involved? How do you define that? What are recognized scientific principles? How do you establish by medical evaluation? What does that mean? Special medically determined nutrient requirements? Can you please give us more clarity on how we would go about determining those? And then the dietary management without modifying the diet alone, what exactly does that mean? And what is the normal diet today? How do we interpret that? And lastly, management of the unique nutrient needs that result. So just how do we define what a nutrient is? What about essential nutrients, conditionally essential nutrients? What about diseases that have precursor nutrients that can get through, but fully formed nutrients have difficulty, such as some of the folate compounds, folic acid and whatnot? What about bioactive dietary substances that we read a lot about? Alternate fuel sources at the cellular level. Think how are ketones used in some cells in the brain and elsewhere in preference to glucose, which we typically think as their fuel source. Is that a nutrient level? Is that a nutrient at the cellular level? And then lastly, compensatory alternative biochemical substrates, pre and probiotics, a big topic that was not really addressed in this medical food definitions that are so old now. We didn't even know that much about them back then. And then signaling molecules we know are so important between the gut and the brain and elsewhere. So in summary, I know this has gone through pretty fast and we could talk hours on this, but just to say medical foods were defined several decades ago, but the definitions and the regulations have not kept pace with all the advances we just alluded to in scientific research. The role of nutrients in food now are known to impact more than just preventing deficiency diseases, scurvy for vitamin C, rickets for vitamin D examples. We now know that the evidence that patients could benefit from specifically formulated products is extensive, but we want to make sure that they are compliant with the existing regulations. And so that makes it a challenge for industry today in their innovative pathways. And then finally, aligning regulations consistent, as I just mentioned, with nutritional benefits, because we also see that medical foods, foods for therapeutic purposes, not a defined term, but for therapeutic, when you can improve the health and the outcomes of a patient through nutritional means, safe nutritional means, there are often very significant cost benefits that can accrue in the overall healthcare system. So I will now turn this over to Manfred Ruthsatz, who will provide an overview of the similarities and differences in regulations between what I just shared with you about medical foods in the US and the food for special medical purpose category in the EU. Manfred?
Okay, thanks, Tim. You will get from me now the European view on what Tim just presented for the United States. You will see a lot of similarities, however, some distinct differences as well. To understand the EU, one needs to understand the regulatory bodies that govern the EU. Keep in mind, the EU is made out of 27 member states after the UK has left earlier this year. And there's the Council of the European Union, the European Parliament, and the European Commission. They all are considered legislative bodies that take their specific role in passing the EU laws or in proposing or enforcing EU laws, what the role of the European Commission is. The European Commission has 27 commissioners, so one for every country or every member state. And the one that concerns us most is the Directorate General for Health and Food Safety, more known or better known as the DG Sante, which is the risk manager and makes decisions on authorizations, whereas whenever there is a scientific question to be handled, be it on food additives, on GMOs, novel foods and health claims, or on these foods for specific groups that include FSMPs, the European Commission mandates the EFSA, European Food Safety Authority, probably the best known institution outside of Europe in the food area in Europe. But they provide an opinion. In theory, the European Commission can follow, but are not obliged to follow. In most cases, they do. In case there is a dispute for a certain category for products that are on the market, there is the EU Court of Justice that determines and interprets the laws and to ensure uniformity across the member states. Keep in mind, in principle, there is should not be any trade barriers between the 27 member states. So after having presented this, you will probably better understand the specifics of where the medical nutrition stands, which is composed of parenteral nutrition, as already mentioned by Tim, which is governed worldwide under medicinal law. The food for special medical purposes, enteral nutrition also called, is governed fully under food law for products that are for the dietary management of a disease, condition, medical disorder. This food for special medical purposes is a harmonized regulation across the 27 member states. And the definitions are remarkably similar with the Codex Alimentarius standards and also the United States Code for Federal Regulation. Foods must be safe when placed on the market. FSMP are being notified. There is no approval required. FSMPs are used under medical supervision, provided also that there is general scientifically agreed evidence, or you have to justify if you deviate from this, and health claims are prohibited for FSMPs. This is the harmonized part across the 27 member states. However, FSMPs would not be very viable if they would not be part of the healthcare systems, hence also being reimbursed. FSMP status is a prerequisite for foods being reimbursable. However, these aspects are not harmonized across the EU member states. It's often based on national, regional, or local organizations, insurers, and also healthcare budgets, and be it public or be it private payers. Private payers, that depends again on the country, are maybe in the range of about 10% of the total reimbursement system. The criteria for reimbursement vary quite significantly by provider and across the countries. And in case that you provide a scientific rationale and or health economic evidence, you may gain in some countries a higher reimbursement. However, typically across the member states, often a complete FSMP serving as a sole source of nutrition is privileged to receive reimbursement. The reimbursement is based on either disease-related malnutrition, that may be as well, of course, available for specific FSMPs that are aimed at managing a range of diseases or medical disorders. Sometimes the only medical component that manages this range of diseases, be it hereditary inborn errors of metabolism, for carbohydrate or protein disorders, severe cow's milk allergies, and also aspects like malabsorption due to short bowel syndrome, or let's say also Crohn's disease, where this is in part of medical association guidelines. The composition criteria may include energy levels and other aspects, other nutrients for infants or for adults, and also different types of proteins, hydrolyzed and non-hydrolyzed. In Europe, like in the US, FSMPs have a long-standing history of safe and beneficial use, also came originally in the 1950s, 60s out as drugs, but then have moved into foods for particular nutritional purposes, and then over the last 20 years into food law for FSMPs. And they have to meet the nutritional and dietary requirements arising from a wide range of medical conditions affecting patients from 0 to the end of life. And key element here as well is that FSMPs cannot be replaced by normal foods marketed to and consumed by healthy people. They have established their place as an integral part of patient management to reduce hospital stays, minimize readmission, and limit the need for other healthcare resources such as medication. It is consistently linked to lower mortality complication rates for malnourished patients, and also helps to reduce healthcare costs across the different systems significantly. All this you find in the report we were compiling with the Medical Nutrition International Industry for better cares for better nutrition, and focusing on the value and the effects of medical nutrition on a global level. So this is not only governing Europe. The publication on the right with the Regulatory Affairs Professional Society is focusing on what we have done in revising the EU FSMP regulatory framework to lay down a foundation for future of nutritional patient care. Very worthwhile to read for those who are want to get deeper into it. So the basis for the FSMP is the Food for Specific Groups Regulation 609/2013, which lays down the requirements for foods intended for vulnerable groups of consumers. The EU has defined 4 of them. With this as well, abandoned the concept of FSDUs for Europe, and specifically for FSMPs, defined a delegated regulation 2016/128 to go further into details about composition. However, as FSMPs are foods, they must as well comply with all the other general food law regulations, with food information to consumer regulation, as well as other food standards with regard to hygiene, contaminants, and pesticide residues. However, keep in mind that this jus generalis is being superseded by jus specialis, so basically a special law for FSMPs. So you are exempt from some parts, but you have to fulfill additional parts. To be an FSMP, it's pretty much like in the US. You cannot cherry pick. You have to meet all the 6 requirements to be processed, specially processed and formulated for the intended use, for the dietary management of patients under medical supervision, for exclusive or partial feeding of patients, and for patients who have limited, impaired, disturbed capacity to take, digest, absorb, metabolize, or excrete ordinary foodstuffs, or contain nutrients contained therein or metabolites, or, and that's also very important, with other medically determined nutrient requirements. And as mentioned already, for patients whose dietary management cannot be achieved by the modification of the normal diet alone. They come in 23 different names, not surprisingly, so the English name is for special medical purposes. This is, however, given the 27 member states, they take the role of to be notified with a simple notification, a form sheet, and a label at the time of launch, and they are as well responsible within their responsibilities to for enforcement matters and monitoring. So the Food Information and Nutrition Declaration, FSMP, says to follow. You would call it labeling. There are specific requirements that the product must be under medical supervision, that the statement whether the product is suitable for use as the sole source of nourishment, just to mention a few. And there are specific requirements on the nutrient declaration that deviate from the regulation 1169/2011, which is the one for consumers. And just to give you one example, so the energy value and the amount of nutrients, they don't need to be expressed as a percentage of the reference intakes, which is quite logical, as they don't make sense for FSMPs. In case you want to develop your own label in different languages, the EU Commission has provided a tool, an electronic tool here, where you can find which category you want to be in. So this is for all foods and also all the 23 different languages. If someone of you is interested to understand really the spirit of the EU Commission guidance for FSMPs, this is a document to go into. It explains the spirit of FSMPs, how to be interpreted as a tool for the healthcare professional to serve their patients. So it's a food, no authorization processes, and the post-marketing supervision is done by competent authorities where the manufacturer takes full responsibility what he does to put products on the market. The EFSA, the European Food Safety Authority, has provided also some guidance with regard to the data requirements. Let's keep in mind that the EU Commission turns to EFSA in case they have a doubt and would like to have the scientific backing for, in particular here, for the so-called Article 3 interpretation decisions. This is something that where the EU Commission reserves the possibility to check if a product is really correctly marketed as an FSMP or not. Key are all the elements I mentioned to you before, and those include as well, is there a nutritional or clinically more advantageous possibility that based on food supplements, that includes as well then how is the disease progressing, how is the impact of poor nutrition, and the adherence to a certain given regimen based on the nutrient requirements determined by the disease, and where the role as well of the healthcare professional that includes as well other, for example, nutritionists, are key to determine these instances on a case-by-case basis. Going into the European Food Safety Authority's guidance on the scientific and technical level, basically they provide what needs to be put into a dossier that you better as a manufacturer keep on file. Keep in mind, you don't need to submit this, but upon question, you need to answer those questions. And this is one of the major differences to the US medical food interpretation, because what counts for the European legislator is their nutritional or clinical advantage. So, if the nutrient requirements for a certain disease cannot be reasonably or realistically being satisfied by modifying the normal diet, and if it's impossible, impractical, or unsafe for patients to consume exclusively other foodstuffs, and that includes the composition, that includes the intended use and instructions for use, including the patterns of consumption, then this can also be defined on a case-by-case basis as an FSMP. This is on a case-by-case basis, and that includes all of these elements, including as well, if there are food supplements or fortified foods the patient could reasonably take, then the product would not be an FSMP as such. And so the practical difficulties of fulfilling the patient's nutritional needs play a key role in determining the status. To give you a few examples, we have in the EU 3 categories across all 27 member states. If the product is nutritionally complete, or if it's nutritionally complete with a nutrient adapted formulation, in both cases, they may serve as a sole source of nutrition. And here you have defined the minimum and maximum levels. You see this on the right-hand side. Here you see as well that there are requirements for infants from 0 to 1 year. So in Europe, this is in one regulation for all age ranges, and for requirements for above 1 year. You have minimum, maximum levels. However, for the nutrient adapted formulation, those levels may deviate depending on the specific disease needs. There's again no authority approval required. Just keep the documentation on file. For the nutritionally incomplete foods with standard formulation or nutrient, here they may not serve as a sole source of nutrition. The maximum levels apply as well, unless there's a reason to deviate based on the disease. Again, keep documents on file. However, here one difference to, for example, the current US interpretation for medical foods, products that are given for swallowing difficulties, even for dysphagia, even though they do not provide nutrients as such, but they allow the patient to keep on for example, a stroke patient, to keep on getting the nutrients from his normal food. Let's say some juice, you just can spoon instead of drinking. And there are different degrees as well of dysphagia. So here, this is still as well considered to be a medical food or FSMP, and that is also outlined in the European Commission guidance. Very illustrated examples, also very worthwhile to read. The compositional requirements, as just mentioned, are based on sound and medical and nutritional principles. The formulation must be safe, beneficial, and effective, and based on generally accepted scientific data. They can be generic, no issue about that. And that is defined again in a regulation of FSMPs 2016/128. Permitted substances, only positive listed substances can be used in FSMPs. Otherwise, you would need to go through a novel food approval process that is determined for foods in general, which includes as well FSMPs. And here are some examples for the 4 categories for vulnerable populations, and the second from the right is for food for special medical purposes. And this is as well, for example, for different essential amino acids, also defined what you can put in there. There are permitted levels. that have, as mentioned, you have minimum levels, maximum levels, and depending on which of those subcategories you're in, you have the possibility to go below or also go above. Lastly, with regards to permitted food additives, they follow again food additive rules, and you have to define as well why you put a certain additive into your products. There are certain categories being defined. There is a community list from which you can pick, and this is a positive list, so you only can use these additives as such. So with this, I would like to hand back to Tim or Alan in case he has joined by now, and to consider what is needed to consider launching a new medical food product, how EAS can help.
Thanks, Manfred. That was very good and comprehensive for sure. So just in closing, I just wanted to point out that if you're interested in launching a new medical food product, this is why we were interested in bringing to your attention EAS Consulting Group's capabilities. And we can help in understanding the constraints, the opportunities for medical foods. We can advise on design of clinical trials that are interesting and important, because if you're trying to show that there's a specific nutritional need in a patient population, the kind of clinical study that you do has to be aimed at the nutritional status of the patient, not the disease outcome, or you risk being considered as a drug. So we have some experience in that area. Pros and cons for the different categories: dietary supplements, foods, FSDU, and as necessary or when appropriate, we have a good relationship with the Food and Drug Administration's infant formula medical food team, which is relatively small, constantly overloaded, but these folks are dedicated to making sure that products for these categories, both infant food and medical food, are safe and meet the criteria that are outlined in the regulations. As Manfred said, we have opportunities to help with EU classifications and guidance. And as part of the larger EAS group and our parent company, we can help with safety assurance of ingredients, GRAS applications when necessary, and claim substantiation. So with that, I would just like to say thank you very much for listening to us. We hope that you learned something perhaps about medical foods that you didn't know before. And we look forward to hearing back from you if you'd like. Here's Alan Saylor, who is our Senior Director of Food Consulting Services.
Great, thank you both. Alan, I'm not actually sure if Alan has been able to join us today.
Okay.
I don't see him out there yet, but we do have a number of questions, so we will just get right to it. The first question, is a clinical required for a new medical food?
I'll take that as you're saying, is a clinical study required for a new medical food?
I believe so, yes.
Well, there is no requirement established for medical foods per se. I would say that if this is a medical food that has not been on the market before, and it depends on the claim or the disease condition that you are intending it to address. The purpose of having the clinical studies is to show that you are able to help a patient in their nutritional management, whether it's correcting for an imbalance in the nutrient status, or let's say in the case of pancreatic insufficiency, this is a hydrolyzed protein that doesn't need digestive enzymes to be absorbed, things of that nature. So I would say that the benefit of the clinical studies, which I recommend in almost every case, is to be able to convince the medical community the doctors who are going to be prescribing this medical food for their patients with a particular disease or condition, that you want them to have evidence that it actually works. And so that's generally the purpose for the research, is that it is effective, and that your claims are able to be substantiated when you say this is to benefit some aspect of a patient with a particular disease.
Okay, thank you. The next question, can foods can make health claims, disease-based claims on nutritive value. Can medical foods make health claims?
That's a good point. And I know it comes up a lot because health claims do have a disease typically in them. But if you think about it and if you look into it more carefully, health claims are intended to tell you that if you have a diet that is rich in certain components, dietary fiber, fruits and vegetables, whatever, it's been shown that you may reduce your risk of developing a chronic disease. That's the typical health claim. And those go through an extensive evaluation process that they require significant scientific agreement from all the studies that have been published. And therefore, those health claims are intended for the normal population and telling them what they could do to reduce their risk of chronic disease. That's not what a medical food is for. A medical food is not for the general population. It's for specific patients that already have a disease or condition that need a medical food to help manage their nutritional status. So they are, as part of the NLEA exemption, they're exempt from nutrient content claims, and they would not be considered a realm for health claims because that's, like I just said, that's intended for the general population, not for those that are already ill.
Okay, thank you. Next question, did GMP requirements for medical foods get updated with FSMA?
You know, I'm not as up to date as the FSMA relationship. We have a whole group of EAS independent consultants that work in that area. I would say, without being the most knowledgeable, that FSMA generally is about the safety and the good record keeping for all manufactured foods. And so as foods, medical foods must comply with those same regulations. I don't believe there's anything uniquely specific about GMPs or good clinical practice GMPs for medical foods that differ that much from regular foods. They still need to have the controls in place, the quality systems, the evidence of your label claims being substantiated by testing, those sorts of things. And I'm not aware that there's any difference with the new updates that were specific for medical foods. But I'm not the experts, and I'm claiming to be. That's just my opinion.
And we will verify with Alan Saylor, our Senior Director for Food Consulting Services, and I'm sure he'll have a comment on that we'll send out at the conclusion of the webinar. I do see a question as to whether we will send slides, and they were sent about 10 o'clock this morning Eastern time. So please check your inbox or perhaps your junk box if you don't see them in your inbox. You're certainly welcome to let me know if you don't see them. And we have time for just one more question. And so that will be, why does FDA not require a prescription or other instrument to demonstrate under supervision of a physician?
Oh, that's an excellent question. One we hear a lot. And, you know, they make the reference that the intention of medical foods is to be used under medical supervision, and they're very clear, as I pointed out, two out of the 5 definitions require that. But a prescription is not required, and that makes it a little bit difficult. How do you ensure that your product is being administered, the patients are under medical supervision? That remains an open question for FDA to address, to define what they would constitute would be evidence that it's under medical supervision. But in that same vein, I would say that also means that the intention of a medical food is not to put it out there in the general population. You are not expected to go into your Walgreens or CVS and find medical foods on the shelf that you as a consumer or as a consumer would choose a medical food, but rather that there would be a recommendation based on your medical situation, based on your nutritional needs, your physician, your healthcare team, which may include dietitians as well, would be the ones recommending a specially formulated product for your need. So I would say it falls more in the realm of what we see precision nutrition or personalized nutrition being a realm that we're working into, that tells you that there's a way to identify you needing a specialized food, but the prescription itself, it's not prohibited. FDA in their guidance the 2016 guidance I mentioned, did not say you could not use a prescription. You can't use the term RX only on your packaging. That's the part that's totally excluded.
Okay, great. Well, thank you both for a fantastic presentation. Thank you for everyone who joined us today. Again, if EAS can be of assistance as you develop medical foods, of course, please reach out to us. We'll be glad to assist. We did record this webinar. I saw that question a couple of minutes ago. So it will be posted on our website in the next few days, and we'll send a link to that recording along with our follow-up information on FSMA. And thanks everyone again for joining us, and have a great day.